It is a case one. It is a 65-year-old male diabetic and I had an exertional angina, function class 2, since last 6 months. Now recurrent angina, including an step source. The ideal diagnostic modality of him would be so one, no test needed. Two, TMT. Three, stress maybe or a CT coronary angiogram. So just I'm leaving to you, and the next five cases I am presenting, and after that we'll discuss in detail. And in last, okay, we'll reveal the answer. Just like it is our routine cases, and routinely we are seeing in the OPD. Just it is like refreshment. The case two, there is a 65-year-old diabetic, and incidentally detected baseline ECG changes. What to do to rule out the CAD? So no test needed or any TMT, exercise stress maybe or a coronary angiogram. So in third one, 50-year-old smoker, hypertensive and Air Force pilot has dyspnea and exertion. ECG echo normal. So wants to rule out CAD. So what is the next test? TMT, stress maybe, CTCAG or CAG. Case 4. In 60-year-old lady for a bilateral TKR and a routine pre-op evaluation. So what to do? TMT, adenosine or dobutamine stress echo or CAG. In case 5, there is a 70-year-old man with the baseline LVB with good LV function, diabetic over 10 years, so want to rule out CAD. The ideal test would be TMT, exercise test may be, pharmacological test may be, CAG. Actually, these are all simple only, but sometimes we will land in the confusion what to do. So how to approach it? If the patient comes to the OPD with those kind of the symptoms, is a CAD evaluation needed or not? If yes, so what is the next step? Is a coronary angiogram or non-invasive evaluation? If non-invasive evaluation, which test is to be done? So is COD evaluation needed? This presentation is only for patients who are asymptomatic or stable CAD, not for an ACS. This please note. And so for every patient who are going for a non-invasive stress test, we need to do an pretest probability, like in a Duke databases. Suppose if you see a 30-year-old man with no chest pain, a typical angina or typical angina, how the things are like in 30. So 3 to 35, 1 to 8 to 59 or 38. It is like a gender and age and chest pain based. So you can see here the 48-year-old male patient with no risk factors. See, very less, and if the with hyperlipidemia, hypertension, and diabetes in asymptomatic patients, it is around 35%. In with atypical chest pain, it is crosses more than 60. If it is a typical chest pain, almost it is around 90%. So the usually the most useful in intermediate probability case, like an 25 to 75% or 10 to 90%. High risk professional like pilots, extra can do in a asymptomatic patient also. So how to approach it? Is CAD evaluation needed? If yes, CAG are non-invasive, the same slide. So if the CAG done in which kind of the things, like in a routine ACS, STEMI, NSTEMI, unstable angina with high risk intermediate. High risk and non-invasive testing also. So what are the diagnostic tools to use? After ECG and echo and routine evaluation, what is the next stress test or any angiogram? So exercise ECG means treadmill test, exercise or pharmacological stress echo, stress or pharmacological stress PT, exercise or pharmacological stress maybe, CT calcium score, CT coronary angiography. So coming to the treadmill test, exercise ECG, it is a widely available, cheap, and no radiation, no IV drug administration needed. So this is a basic involved. The next one is exercise ECG, when not to do. ACS, when there is an LV dysfunction, always do an echo before TMT. and the patient is with CHF and any arrhythmias, any baseline ECGs, and the left bundle block, and the left ventricular hypertrophy, pre-excitation, digoxin drugs usage, electrolyte imbalance, paced rhythm. These are the contraindication for a treadmill test. Pharmacological echo means like in a dobutamine echo and exercise echo. So it is a exercise echo and pharmacological echo is more sensitive and specific than TMT. The pharmacological dobutamine when the patient can't exercise, and this is advantage is the no radiation. Takes less time. Difficult when window is not proper. Most sensitive, less specific than that stress echo. Shows location. This is about an aspect. Shows location, event, severity of ischemia. Exercise test if the patient can exercise, and adenosine if the patient can't exercise, and LBB or with any ECG changes. Dobutamine if the contraindicator to adenosine like asthma, heart block. Disadvantages: costly, radiation, artifacts, limited availability. The pharmacological or exercise cardiac MRI rarely used. Exercise usually not feasible. Dobutamine commonly used. No radiation. Excellent definition of the heart borders, but limitation of the usage is the problem. Equivalent to the spectre. The CT calcium score used in the age more than 40 years with intermediate atherosclerotic cardiovascular disease, and with men with diabetes 35 to 38 years, men without diabetes for more than 40, and women with diabetes more than 49, and women without diabetes more than 50. Easy, no risk of contrast. If the calcium score is 0, no identifiable disease. If it is 1 to less than 100 is mild, and more 100 to 400 it is moderate, more than 400 is severe. So CT coronary angio will reveal anatomical information, high sensitivity and specificity, can use in a low intermediate probability, even who have a strong family history, accelerated atherosclerosis and familial hyperlipidemia. In emergency, for an intermediate probability cases, issues, the contrast, allergy, renal issues, radiation, heart rate control, regular heart rate needed. And this is a sensitivity and a specificity of our diagnostic tools, like an NTM treadmill test. It is a sensitivity is a 45 to 61, and the specificity is around 70 to 90%. Exercise stress echo 70 to 85 and 77 to 89% specificity. Exercise respect is around 73 to 92 and 63 to 88 specificity, and pharmacological stress echocardiography. So 72 to 90 and 79 to 95. The pharmacological stress spectrum 88 to 91 and 75 to 90, and coronary CT is 93 to 99 and 64 to 90. CH is the gold standard. It is 100% in both cases. And if you I ideally we use a treadmill test, and dobutamine stress echo we commonly use next CT coronary angiogram and angiogram. So these in these four, actually the dobutamine stress echo, if you go for depending on the lesion, obstructive lesion, actually there is a sensitivity variation also is there. Suppose if it is a single vessel disease, is 74% sensitivity. If it is in a double vessel, it is 86, and if it is in a triple vessel, it is 92. So depending on the lesion severity, it increases. So approach to choose patient. Can the patient exercise or not? Is the baseline ECG is normal or not? Can exercise and baseline ECG is normal? So if the patient can exercise and baseline ECG normal, TMT is the ideal option. And if the patient is can exercise and baseline ECG is abnormal, then stress echo or stress spectre. These are the ideal options. But the problem is the cost and availabilities with the stress. And the patient can exercise and baseline ECG is abnormal in that adenosine or dobutamine stress echoes. Adenosine is contraindicated in airway disease and heart blocks and hypotension, and dobutamine is contraindicated when arrhythmias or LVOT obstruction and uncontrolled hypertension. If the patient is ECG is normal or abnormal but can't exercise, the pharmacological stress echoes. So this is a summary. If the patient is exercise, if the ECG is normal, yes, then TMT go for it. If there no, and then stress ECG. There is no LBBR we face, and the patient ECG LBBR we face, then adenosine stress may be, and this is a stress may be. And if the patient is not can't exercise, pharmacological stress test, like in a dobutamine in a preoperative preferred, or otherwise you can go for an stress maybe, or if contraindicated, go for an adenosine is contraindicated, go for an dobutamine. So when you come to the initial cases, the patient the 65-year-old diabetic with exertional angina class 2 since last 6 months, including in rest phases. So what to do? The patient has an angina during rest. There is in diabetic. Okay. The next option is the any answers? What can be done? So there is no stress test is needed, and directly you can go for a coronary angiogram. And the case 2, if then a 65-year-old diabetic and incidentally detect on a baseline changes to rule out CAD, and the ideal test would be the stress maybe, exercise test maybe. In case 3, the patient with smoker and hypertensive and Air Force pilot has dyspnea and exertion, and ECG echo is normal, and then so you have to assess the pretest probability as like before, and then you can go for an see if the patient comes to this range. So TMT is the option. In case 4, actually the 60-year-old lady with preoperative bilateral TKR. So the patient with knee coming for knee replacement, can't exercise, and so TMT is ruled out. So ideal to rule out is the dobutamine stress echo. In case 5, 74-year-old male, elderly with baseline LVV, so stay with good LV function, and stress echo and TMT was ruled out, and stress maybe is the option. So these are the situations. So where to use our diagnostic tools. The basically treadmill test, stress echo, pharmacological stress echo, and CT coronary angiogram and angiogram. So when to refer for an angiogram, these are the important. So I have done with my presentation. Thank you, everyone.
Thank you so much, Dr. Madhukar. Any comments from Dr. Pankaj and Dr. Anshuman Full, or any faculty member who wants to say something? Any comments, any questions? Most welcome. In that case, we can move to our next talk. Thank you so much, Dr. Madhukar, for your nice presentation. Requesting Dr. Madhukar to kindly withdraw your slides. Thank you so much. So, humbly requesting to kindly accept the certificate of presentation, faculty certificate, to Dr. Madhukar Cheerla and Dr. Anshuman Full and Dr. Pankaj Kumar for chairing the session and as a speaker. So going ahead with our next topic. So we have hemodynamics in echo. The chairperson for the session is Dr. Rajkumar from Oman. He is Vice President of IACC and President Karnataka Chapter IACC. He has publications, fellowships, and memberships to various organizations. And Dr. Sudipta Sinha is clinical cardiologist at Ranchi. Dr. Anshuman is a life member of Indian Academy of Echocardiography and Indian Association of Clinical Cardiology, along with American College of Cardiology. He is consultant at Max Hospital and BLK Super Specialty Hospital. With these few words, I hand over the session to Dr. Anshuman for his presentation on hemodynamics in echo. You can share your slides, Dr. Anshuman. It's over to you now. Dr. Anshuman, are you there? Dr. Anshuman, are you there?
Dr. Vineet, I feel there is some connection problem with Dr. Anshuman. If it is okay, meanwhile, we can proceed with the next.
Would you like to present Dr. Rajesh?
Yes, go ahead. I will present.
Okay, fine. Okay, fine. Just a minute. So since Dr. Anshuman is taking some time, in the meantime, we will go with Chairman's keynote address from Dr. Rajesh Rajan, who is Chairman to Board of Governors, Indian Association of Clinical Cardiologists. He will be presenting on cardiac steatosis and diabetes with latest updates. Dr. Mohammad Shafiq, Governor, IACC, and Dr. Jiaul Haq, Clinical Cardiologist, Devgar, will chair the session. Dr. Rajesh Rajan is a graduate and postgraduate with fellowships to various associations, including European Society of Cardiology, American College of Cardiology, and Heart Association. He is presently cardiologist at Al Ahmad Cardiac Center, Kuwait. He is managing director to Annals of Clinical Cardiology, president of AMDP, and in charge of various clinical research registries in heart failure. Recently, he has developed a heart failure score, which has been very much applauded and has several publications. I guess we do not have the numbers. He is also on editorial board of various cardiology journals. For his chairman's address, we humbly request him to accept the medallion, the certificate, as well as the memento prior to his presentation as its chairman's keynote address. With these few words, I hand over the session to Dr. Rajesh Rajan. Over to you.
Thank you, Vineet ji. Thank you very much. Let me share the screen. So today's topic is diabetic cardiac steatosis. So Dr. Vineet, the screen, you can see the screen, right?
Yeah, it's
Okay,
visible.
thank
It's
you.
full. Yeah.
So the growing interest has been accumulated in the definition of worsening of effect of diabetes in cardiovascular system. And this is associated with epidemiological data regarding higher incidence of heart failure in diabetic patients. To investigate the decremental effect of both hyperglycemia and insulin resistance, a lot of preclinical models were developed. However, the evidence of pathogenic and histological alteration of the so-called diabetic cardiomyopathy. So we are concentrating today on this particular topic. There are several stress factors which can stressors which can cause diabetic cardiomyopathy. It can be divided as metabolic stressors and biochemical stressors, which leads to metabolic injury as a result of this developed diabetic cardiomyopathy. So in case of this metabolic remodeling, because of the hyperglycemia, oxidative stress, ages, mitochondrial dysfunction, abnormal calcium homeostasis, and free fatty acid metabolism, and all these things happens in diabetes, and because of this there can be microvascular dysfunction and metabolic remodeling happens, and due to this subclinical remodeling there can be inflammation, extracellular matrix alteration, diastolic dysfunction sets in. All these stressors and factors which can lead to heart failure, and we named it as diabetic cardiomyopathy. In a diabetic cardiomyopathy, as we already discussed, due to this insulin resistance and hyperglycemia, there are several factors which contribute these things, like impaired calcium handling, lipotoxicity, the advanced glycation end products, which we called as age or ages, the increased oxidative stress, increased free fatty acid utilization, and fibrosis sets in, which can cause this diabetic cardiomyopathy. At the same time, there can be the endoplasmic reticulum stress, mitochondrial dysfunction, RAS impairment, essential impairment, microvascular dysfunction. So all these factors can affects the heart and ultimately sets into diabetic cardiomyopathy. And because of this diabetes, as we already discussed, this the effects of hyperinsulinemia, insulin resistance, and hyperglycemia, there will be inflammation, dyslipidemia, and endothelial dysfunction. All these three things can cause coronary artery disease and ultimately sets in ischemic cardiomyopathy and develops the diabetic cardiomyopathy. On the other side, there can be cardiomyocyte hypertrophy. RAS activation can cause this thing, and there is an impaired calcium handling or autonomous dysfunction, which all these things can cause fibrosis and ultimately sets into diabetic cardiomyopathy, and heart failure sets in diabetes. So the excessive free fatty acid delivery, in the setting of this excessive free fatty when it is associated with obesity and type 2 diabetes, the free fatty acid uptake can by the cardiac myocytes exceeds the mitochondrial oxidative capacity, which may be additionally impaired by several putative mechanisms. The resultant lipid storage, the over storage, which is called cardiac steatosis, produces lipotoxic intermediates such as ceramide and increased production of reactive oxygen species we call as ROS, which causes apoptosis. The combination of this increased free fatty acid delivery to cardiomyocytes seen in obesity and type 2 diabetes, coupled with impaired fatty acid oxidation seen in heart failure, leads to myocardial steatosis. So there are several stages of diabetic cardiomyopathy. In the stage 1, there is a diastolic dysfunction. In stage 2, there will be systolic and diastolic dysfunction. In stage 3, there will be an association of the systolic and diastolic dysfunction with microvascular diseases and coronary atherosclerosis. And stage 4 is overt ischemia and causing heart failure. So the pathological mechanisms we already discussed. So these are the 4 stages you can see in diabetic cardiomyopathy. For diagnosing this particular diabetic cardiomyopathy, we can use cardiac MRI. So the left ventricular diastolic dysfunction can be assessed using the flow velocity encoded cardiac MRI. Using cardiac MRI, the myocardial diastolic functional parameters have been shown to associate with myocardial triglyceride accumulation in healthy volunteers. The lipid staining was also seen in obese and type 2 diabetes patients with end-stage heart failure. So the magnetic resonance spectroscopy, you can see in this spectroscopy, the dark gray areas which is the cardiac muscles, and the white areas which can be the blood or the pericardial fat. And this is the volume testing for myocardial triglyceride content is placed, and you can see in this graph the tissue metabolites, how it comes, and the myocardial triglycerides. So this is the one method which by which we can diagnose cardiac steatosis, or so-called diabetic cardiomyopathy, or increased triglyceride content in the heart muscles. So in addition to this myocardial accumulation of triglycerides in type 2 diabetes, there will be increased visceral adipose tissues which associate with the elevation of circulating plasma triglycerides and non-esterified fatty acids, and contributes to lipid overexposure to non-adipose tissue compartments. So the excessive triglyceride storage enters into a continuous cycle between hydrolysis and fatty acid re-esterification, yielding to cardiotoxic intermediates such as ceramide and diglycerol, which seems to be an important route leading to myocardial dysfunction. So here, basically, we are going to talk about reactive oxygen species and what is the role of the particular treatment for the to encounter this diabetic cardiomyopathy. So the oxidative stress, defined as an imbalance of reactive oxygen species, has increasingly proposed to contribute to the development of diabetic cardiomyopathy. The overproduction of ROS in diabetic cardiomyopathy is thought to be counterbalanced by the elevated antioxidant defense mechanisms such as catalase and superoxide dismutase. The excessive ROS in cardiomyocytes result in further production of ROS in the mitochondrial DNA damage, lipid peroxidase, and cross-transitional modification of proteins, and ultimately cell death and cardiac dysfunction. So these are the pathological mechanisms happens when there is an increased reactive oxygen species. So these ROS modulate transcription factors are responsible for the expression of antioxidant enzymes. Lastly, the evidence exists that several pharmacological agents that convey the cardiovascular benefits by antioxidant mechanisms. So the pathway that leads to increased ROS production and impaired antioxidants defense may enable to the development of therapeutic strategies against this progression of diabetic cardiomyopathy. So this is what we were talking in the last slides. Because of the diabetes, there can be increased production of ROS. And so there are several drugs which are used in diabetes, like SGLT2, GPL1RA, DPP4, ARB. So these are the several drugs which can stop this increased, as well as the natural antioxidants and ROS scavengers can stop this increased production of ROS, and we can stop the further development of this mitochondrial dysfunction or myocardial hypertrophy, cell death, fibrosis, and contractile dysfunction, and ultimately sets into this diabetic cardiomyopathy. So pioglitazone, such a drug, a paroxysmal proliferator activator receptor gamma agonist, which has the capacity to divert fat from non-adipose tissues to subcutaneous tissue, has shown to lower the myocardial triglyceride content in diabetic patients on an insulin-based treatment regimen. And therefore, the myocardial triglyceride may be a useful indicator of myocardial cardiac steatosis for predicting the severity of diabetic cardiomyopathy and for evaluating the effects of anti-steatotic therapy. So these are a few studies done by our team You can see the impact of diabetes on mortality and rehospitalization in acute heart failure patients stratified by the ejection fraction. It was published in ESC Heart Failure Journal during 2020. We found that there was no significant difference in 3 months and 12 months all-cause mortality, as well as the rehospitalization rates between the diabetic and non-diabetic patients in all the 3 heart failure groups stratified by left ventricular ejection fraction. Also, another study we published in Oman Medical Journal during 2020. The mortality and morbidity in heart failure with reduced ejection fraction, mid-range, and preserved ejection fraction in patients with diabetes in the Middle East. And we found that there is a 3-month cumulative all-cause mortality was high in diabetic patients with reduced ejection fraction when compared to those with the preserved ejection fraction. So thank you very much. If there is any questions, most welcome. Over to Dr. Vineet.
Thank you. Thank you so much, Dr. Rajesh. Any questions for Dr. Rajesh? Any questions for Dr. Rajesh?
So if there is no questions, thank you very much, Dr. Vineet. I have to go for OPD in the middle of work. Thank you very much for inviting.
Thank you. Thank you so much. I request Dr. Rajesh to kindly withdraw his slides. That was a wonderful presentation, Dr. Rajesh. Very lucid, very brisk. Thank you so much.
Yeah, thank you. Thank you, Dr. Vineet.
Who will take the next talk? Dr. Anshuman is here and Dr. Pragnesh is here.
Yeah, I will take the next. I will take the next.
Okay, fine. Yeah. Dr. Anshuman, can we take after Dr. Pragnesh?
No issues.
Okay, thank you so much.
So, Dr. Vineet, happy Independence Day, Dr. Pragnesh. Nice meeting you.
Yeah. Yes, happy Independence Day to all.
Thank you so much. You all have been sparing so much of time of yourself, OPD, indoor, everything. Thank you so much. So, our certificate for our chairpersons, Dr. Shafiq and Dr. Ziaul. Moving on to our next session. This is our flow of the meeting. Our scientific partners, ClearNet is here to support us. We celebrating 75th Independence Day of India. These are our volunteers who are helping us. So, Dr. Kaushik Chaki and Dr. Rakesh Kumar, clinical cardiologists from Calcutta and Ranchi, are the chairperson for sexual activity and cardiac diseases. Dr. Pragnesh Shah, who is organizing secretary for the upcoming IACC Con 2022 at Vadodara, is clinical cardiologist. So with these few words, I request Dr. Pragnesh Shah to kindly take up the session from this place and present his talk on sexual activity in cardiac diseases.
I'm not able to share my screen.
Evelina, can you help Dr. Pragnesh?
Yes, so what kind of issue you are facing?
Yes. Now.
Please go ahead.
Okay, I am audible and visible.
Sir, sorry to interrupt. It's not in full screen, sir. Have you clicked on that?
Dr. Pragnesh.
It's a full screen.
But sir, I guess we can't see the full screen. It's not full screen from our end.
Is my screen is visible to you, all of you?
Yes, the PPT is visible, but not in full screen.
But it is the full screen.
Okay, so then you can do one thing. You can stop the sharing, close the PPT, and share your entire screen, sir, not the PPT one.
Okay, yeah. I just stop sharing.
Yeah, close the PPT also, sir, and share your entire screen.
Okay, yeah. Now I will share my
like the first option, screen or entire screen, anything.
Entire screen. Entire screen I will share.
Yes, sir.
But it is not possible.
But you can see, sir, like what it is coming.
Just a minute. There is some technical changes, I think so. Chrome tab is not there. Entire screen. I'm not able to share the screen.
So, I mean, what you can see on your screens after clicking enter screen, the share screen is not coming, sir, like at
No,
the
no.
bottom.
Yes. Share screen is not coming. I'm not able to share my screen.
But sir, you are allowed to share. Can you please try again?
Let me try again. Yes. No, it's not allowing me to share.
But sir, you are allowed and you have just now shared your screen. So the green colored option is coming to you, share screen.
No.
Yes,
Is
sir,
it?
you have shared your screen again.
Yeah. Okay. Yeah. So now is it visible?
Yes, sir, it's the slide is visible, but not in full screen. So that's the
But,
issue.
but it is the full screen. Okay, we will go by this only.
Yeah. So you can
Yes.
like the just remove the full screen and go ahead, sir.
Yeah. Uh, yes. Good morning, friends, and many congratulations to Dr. Jagnany for organizing the successful series of the CARDIOZONE, and happy Independence Day to all of you. Now the topic is sexual activity and cardiac disease. See, the reason behind to keep this topic is most younger adults who experience an acute MI are sexually active before the acute MI episode, but little is known about sexual activity or sexual function after the event. And it is very much sure that it is neglected area from both sides, from the doctor side and from the patient side, due to the social stigma. And nowadays, heart disease are common in the age group less than 40 years. So let me ask one question: how many of you are asking question about sex life post PTC or post MI patient or any patient with cardiac disease? And do you feel that this is a really an important issue to address by treating doctor? I request all of you to message in the chat box. How many of you asked the question about sexual activity post MI or other cardiovascular diseases? So this is the case almost before 12, 14 years that a male of 36 years of marriage life had a inferior MI and for that PTCA was done and his ejection fraction is 60%. TMT is almost 12 minutes without symptom post 2-month PTCA. But there is a myth that stent means no sex. So they have some personal issues and divorce 8 months post PTCA. And the reason is absence of sexual activity. The bad part is there is no counseling about sex life post PTCA done. Either the patient is asking the question or not by the medical service providers. So let's see what is the science is talking about sexual activity post cardiac events. So this is a very good articles on the National Library of Medicines is telling that cardiovascular changes resulting from the sexual activity and sexual dysfunction after MI. So they concluded that because sexual dysfunction negatively affect the lives of people, providing guidance to individuals with cardiovascular disease, especially after acute MI, may be crucial factor in determining quality of life and should be incorporated in day-to-day clinical practice. This is a very good point discussed in the Medscape that we all have a mental setting in our mind that sexual dysfunction has traditionally been domain of the psychiatrists, urologists, or gynecologists. But with the growing recognition of sexual dysfunction and cardiovascular disease, often the general practitioner and the cardiologists are now getting into the act to resolve this problem. In one article in 2015 of American College of Cardiology, they said that it may be safe to resume sexual activity following myocardial infarction, and MI is rarely caused by sexual activity, according to a research of this paper, which is published again in September 2021. Now, in the September 20, resuming sexual activity soon after heart attack linked with the improved survival, this paper is conclude with that returning to the usual level of sexual activity within a few months after a heart attack is positively associated with long-term survival. Sexuality and sexual activity are marker of the well-being. Resumption of the sexual activities soon after the heart attack may be a part of one of the self-perception as a healthy, functioning, young and energetic person. This may lead to a healthier lifestyle generally. Maintaining or increasing the frequency of sexual activity within the first 6 months after a heart attack was associated with 35% lower risk of death compared with the absent or reducing frequency of sexual activity. So these also we should keep in the mind. Now that European Association of Preventive Cardiology also concluded in January 2022 that results of the sexual activity frequency within the first month after MI was strongly associated with improved long-term survival, highlighting the need for the sexual counseling shortly after myocardial infarction. Now, Canadian Journal of Cardiology said in a very good article of what sex is safe for the heart patient, a new approach using ketomy model. This is a very good model. We will discuss in the next slide. But they said that kissing and touching is as good as slow walking. Then there are different kind of sexual activities, and they said that to reject the organism with a we will use the almost get a 3 to 5 minutes, and it is as good as we cross the street on the moving vehicle. It is the faster activity. So they during this Canadian Journal of Cardiology, this article, sexual activity in heart patient, in this article they said that sexual activity, particularly coitus, may be major aspect of health-related quality of life, and is often considered the most pleasant and rewarding exercise performing during the entire life. They also said that considering the rationale for the exercise prescription, sexual activity is typically well tolerated by the most clinically stable patient with the heart disease. And they advise to follow the ketone modules. Now let's discuss what is the ketone modules. They said that patient with the low risk, it means the stable angina, patient with controlled hypertension, it means they are almost getting 3 to 5 minutes on the treadmills. They should follow ketone models. It means ketone is the abbreviation of this. Kit means kissing and touching. Ketone means kissing, touching, and oral sex. And ketone means kissing, touching, and all. These are the different activity what the human being is performed during the sexual activity. So they said that low risk patient can participate in the ketone modules. Then intermediate risk, it means that patient is having a NYHA symptoms of class 2 or 3 or the moderate stable angina, and those who are performing 2 to 3 minutes in the TMT, they can have a ketone models. And patients are high risk. There are unstable angina. They are not able to NYHA class 3 or 4 group of patients. They can follow the KIT modules. It means also kissing and touching. The sexual activity and counseling in the first month after the acute MI among the younger adults in United States, that studies was that they said that sexual activity may be resumed after 1 or more weeks by a patient with uncomplicated MI and without cardiac symptom during the mild to moderate physical activity. The European Society of Cardiology says that resumption of the sexual activity after AMI should not be lethal if patient is able to tolerate the physical activity. About the sexual activity in angina, they said that coital angina, also known as angina of Daimler, that occurs during the minutes or hour after the sexual activity represent less than 5% of all angina attacks. It is rare in a patient who don't have angina during the strenuous physical exertion, and more prevalent in sedentary individuals with severe coronary artery disease who experience angina with minimal physical activity. So if a patient can achieve an energy expenditure of 3 to 5 minutes without demonstrating sign of ischemia during the exercise testing, then risk of ischemia during the sexual activity is very low. In the one article at circulation, they recommended for the sexual activity for the coronary artery disease, that sexual activity is reasonably for the patients with no and mild angina. Sexual activity is reasonable 1 or more weeks after uncomplicated MI if patient is without cardiac symptoms. And also they said that sexual activity after CABG they can perform after the wound healing or 6 to 8 weeks after the CABG. Then other non-coronary open heart surgery same after the 8 weeks of the sternal wound healing. And then sexual activity should be deferred for the patient with unstable and refractory angina until their condition is stabilized or optimally managed. Now, it is the same thing, the patient with stable IHD, previous MI and post-PTCA, if they are able to perform the moderate activity, exercise level or 3 to 5, or they are able to cross 3 to 5 minutes on the treadmill, they can actively participate in the sexual activity. The recommendation for the post-CBG and non-coronary open heart procedures, it is generally recommended that sexual activity be delayed for 6 to 8 weeks after CABG or non-coronary open heart procedure. After successful recovery after CABG, sexual activity is usually resumed and sexual satisfaction is usually maintained for many patients. Now for the heart failure, they said that sexual activity is reasonable for the patient with compensated and mild heart failure. It means NYHA class 1 or class 2. But sexual activity is not advised for the patient with decompensated or advanced heart failure. It means patients falling in the group of the NYHA class 3 or class 4. They can resume the sexual activity once they have stabilized or with the optimally managed pharmacological management. Now about sexual activity and valvular heart disease, they recommended that sexual activity is reasonable for the patient with mild to moderate valvular heart disease and no to mild symptoms. Sexual activity is reasonable for the patient with normally functioning prosthetic valve, successfully repaired valve, and successfully transcatheter valve intervention. And sexual activity is not advised for the patients with severe or significantly symptomatic valvular disease until their condition is stabilized and optimally managed. And some recommendation for the sexual activity and congenital heart disease. So sexual activity is reasonable for most congenital heart disease patients who don't have decompensated or advanced heart failure, severe and significant symptomatic valve disease or uncontrolled arrhythmia. Now, what's the recommendation about arrhythmia, pacemaker, ICD for the sexual activity? They said that sexual activity is reasonable for the patient with atrial fibrillation and atrial flutter and when controlled ventricular rates. Sexual activity is reasonable for the patient with history of atrioventricular nodal reentrant tachycardia, AVRT, and atrial tachycardia, and also the controlled arrhythmia. Sexual activity is reasonable for the patients with pacemaker or ICD implant for the primary prevention. Sexual activity is reasonable for the same thing, ICD for the also for the secondary prevention, in whom moderate physical activity does not precipitate ventricular tachycardia or fibrillation and who don't receive frequent multiple appropriate shocks. This is more important for the patients with ICD or AICD. Sexual activity should be deferred for the patient with AF and poorly controlled ventricular rate, uncontrolled and symptomatic supraventricular tachycardia, and spontaneous exercise-induced ventricular tachycardia until the condition is optimally managed. And sexual activities should be deferred in the patient with IACD who have received multiple shocks until the positive arrhythmia is stabilized and optimally controlled. Sexual activity and HOCM, though it is reasonably good for the most patients of the HOCM, but sexual activity should be deferred for the patients with SCM who is severely symptomatic until their condition is stabilized, and SCM with severe outflow obstruction. Cardiovascular drugs and sexually functions. So cardiovascular death can, this is very good recommendation that we all should keep in the mind that cardiovascular drug that can improve symptoms and survival should not be withheld because of the concern about potent impact on the sexual function. And what about the topical and local estrogen therapy? So they said that non-systemic estrogen use for the treatment of dyspareunia in women with CVD is reasonably good. Herbal medicine, they said that it may be reasonable to caution patient with CVD regarding the potential for the adverse effect of the use of the herbal medicine with unknown ingredient that are taken the treatment for the sexual dysfunction. And they always emphasis on the patient and partner counseling both. That patient and spouse counseling by the healthcare provider is useful to assist in resumption of sexual activity after an acute cardiac event, new cardiovascular diagnosis, and ICD implantation. Usually, I counsel both the partner post CABG and post any cardiac procedure after 2 weeks in each and every couple. And I insist the patients to come with the spouse for that matter. Sexual activity and PD5 inhibitors, we all know that it should not be combined with the nitrates, and they said that PD5 inhibitors should not be used the patient receiving nitrates, and nitrates should not be administered to the patient within 24 hours of the sildenafil administration or the within 48 hours of the tadalafil administration. But they said that you can give sildenafil or tadalafil for the treatment of erectile dysfunction in patients with a stable CVD. So, the counseling of the patient with the cardiac disease regarding the sexual activity advice must be individualized. In a general, if patients are stabilized, they may resume normal sexual activity within 2 to 6 weeks. A graded ETT exercise treadmill test may be the value in the higher risk patients. The clinician must be alert to potential medication effect that may be a contributing factor to the sexual dysfunction. Patients should be warned of symptoms with sexual activity that should generate evolution. For example, palpitation, shortness of breath, angina, fatigue, etc. And alert their physician should this occur. And finally, the physician should be proactive in assessing and counseling patient regarding sexual functioning. And in general, if the patient can achieve 5 minutes on exercise treadmill test without demonstrable ischemia or significant arrhythmia or any symptoms, they are generally not at high risk to resume normal sexual activity. Similarly, if echocardiography does not yield evidence of more than moderate LV dysfunction, resumption of sexual activity is probably safe. Herewith, I would like to invite all of you for the upcoming 11th National Annual Conference of the Indian Association of Clinical Cardiologists IACC 2022 at Vadodara, Gujarat. कुछ दिन तो गुजारो गुजरात में. Thank you very much. If any question, I would like to answer.
Excellent presentation, Dr. Pragnesh. I think it's one of the star presentation of CARDIOZONE we should consider, because this kind of presentations are not seen in most of our cardiology conferences, and love to hear this. And I think such presentations should be encouraged in most of our conferences, which is very clinically valid for the clinical cardiologist who is treating this kind of patients post CABG, post ICD, post HCM therapy, and all those things. So basically,